Okay. I think I do have this financial interest. Can I have my slide, please? Projection, yeah. There may be some, keep in mind what is written here. Maybe you interpret differently what I say. But what I am going to say, and recognized by Shali and many others of my clinic, that we have realized over the years, and Sanjay and many others sitting here would agree, that we struggled to achieve clear cornea. In my 25 years, I never could achieve a clear cornea day one in all grades of cataract. We achieved that and we thought we are on the moon. But no, not sir, not enough now, because the demand has changed and the convenience, and we are not talking about the refractive surgery, and we are talking about improving the lifestyle and unaided vision on top of that, my God. So clear cornea, the mechanical outcome is elementary in Dr. Watson's language, but that's not enough. You need to now enhance, and we heard how you can prepare yourself by diagnosis, how you can handle the astigmatism, which is the astigmatic defocus is more lethal than the ametropic defocus. 0.5 diopter of astigmatic defocus is worse than 0.75 spherical defocus. Remember that. So treating astigmatism, as we learned from the master, is remain, and we heard Samraj talking about separate time and taking both eyes together. But if you have a chart like what we have here, it will help the team to tick. And if you want to do all 21 in as many patients as we can during the preoperative workup, and that's why we needed separate team, separate time, and lot of time, every patient. When Vandana and Lajja see this preoperative 7-8 patients, they take 3 hours to see 7-8 patients, because they have to go through all that and talk a lot of things. And because we want to treat each one one-to-one. Time has gone where see 50 patients in a row towards, I was trained that way. 100 patient OPD as a registrar, and my boss was very happy that I could have a lunch, 2.5 hours time. The days are gone. So each and every patient deserves and made for you, sir, ma'am, this is different. Because you understand the person, you understand the eye, and therefore you're ready to do that and cater that. So every aspects of that individual aspects, personality, the work and hobby and whatever else will help you. And how do you do that? There are many ways. A good clinician, moment the patient walks in, understand this is not the patient I want to suggest, because look at his face, his body language. No, you go on this side, sir. But if you have a questionnaire, like as you can see here, and you can prepare your question, it's not a rocket science. Prepare 6 questions of your style, in your culture, in your practice, wherever you're doing. And you will be amazed that you will be able to net, as the Americans call it, more patients for these advanced technology IOLs. And you can do that, but here, you always involve family members, because the parents sometimes are so kind, they don't want the son to spend more money. And say, no, I'm not good reading sometimes. And say, no, you like that. No, Papa, you want to do that. Why not? So involve the parent. Maybe that will help the parents or vice versa. And, everyone will benefit in the process. Now, today, I must say, when we say multifocal, we really mean trifocal. The trifocals have taken over multifocal, generally speaking. That's not 100% a statement, but generally speaking, it is getting so widely adapted that the traditional multifocal of great lenses, and we enjoyed it. My own family members have those lenses, and they still love it. But I think we now want to move on and consider trifocals whenever you are considering this so-called two-focus lenses. And optically speaking, this has to happen. If there is a distance focus at 0, the near has to have 40 centimeter if you add anything. That is how the wavefront does it. And therefore, it will be intermediate 80 centimeter. This, you cannot change it unless you play with that optics. And playing with that optics is not an easy job because it adds into some other things. So traditional trifocals will have an intermediate at 80 centimeter, near at 40 centimeter, and far away. And that works well for the people who want to work at 80 centimeter, and that will be the right lens for that particular individual, remember. But many of these patients would be working at lesser distance than 80. 80 centimeter for me is this. 60 is this. So, you know, the lenses which can, how can you make it 60 centimeter? And some studies, surveys showed that 60 centimeter is the most widely used. 80% of the population globally have a 60 centimeter intermediate distance, maybe plus or minus, not necessarily 60 perfect, but that's why. But what is that intermediate distance? What do you mean by intermediate distance? Intermediate distance may be different for different people. As I say, my friend here would have a 50 centimeter, and the one guy there will have a 60, 70. So that's what you depend. But generally speaking, it is around 60 centimeter, and it is so important in lifestyle. We talk about lifestyle, improving lifestyle. We never give a damn to intermediate. We never gave it for, I never gave it for last 37 years. It's only last 6, 7 years that I understood there is a thing called intermediate distance. I never was told that there is a third distance called intermediate. Believe me, in my career. Distance and near, that's it. So it's so important that we pay attention, and industry has taken up smartly and has produced one lens after another one to cater that need and demand that they have. And intermediate could be various things depending upon your thing. And this is an example of a panoptic lens, which is a 60 centimeter intermediate. But this applies to all the trifocals, and there are wonderful trifocal lenses. Most of the companies make it. So this is, you can take it for all the trifocal, generally speaking. But this one is a unique feature of a 60 centimeter intermediate. And this is my daughter's class teacher. She trained taught my daughters, and very fond of this mental game, which I can't even look at it. I get headache. and she had a bifocal, bilateral trifocal, and she's very happy. This is an active lady, 80 years plus, and she's forgetful. And how many of you are forgetful in this hall? I am. My memory is losing now. So they couldn't remember, where is my mobile, where is my glasses, where is my, they had to ask the children, where is it? Do you see my mobile? Please ring me. Like that, she couldn't find it, remember. So we put a, you know, we thought of it, putting a multifocal, trifocal, and she was suitable. We did a bilateral trifocal lens, and just told her that use the light. Don't read in the corner of the room, or sit under the light or near the light, because whatever the companies say, all of these lenses would need a little extra light. That a little could be little for industry, but for patient, it's a bloody big light. So remember, the light will be an issue, generally speaking, which with age and whatever other distracting technology, diffractive IOLs particularly would have more. So the age is not a bar for trifocal lenses. That we know it, but we are hesitant to suggest that 80. And she is so philosopher-like, and you're reluctant. You don't want her to spend more money because you are doctors. You are the cream of the society, so you are considerate for others. And you say, I don't want her to spend more. I want to economize for because I am a noble professional. But the world and the society in India is teaching you something different recently. So this is what the life is all about. So don't hesitate. They deserve it, and you deserve it, of course. So this is an ophthalmologist in Madhya Pradesh, very active practitioner. And if I have a cataract surgery, I may consider him as my surgeon. He's such a brilliant surgeon. And he does multifocal and all kinds of things. He's very up-to-date surgeon. Keep abreast with him, and he developed cataract, and he was motivated for multifocal because he saw his smile on his patients with multifocals. So he said, you know, why not me? So As you can see, he had to use operating microscope, slit lamp. He was driving at night because he had a nice car. I don't have it. Keen on multifocal because of what I say. So we were very careful because, we don't know. So we thought it's technically suitable, but we said, come on now, sit down, have a coffee. You know now that you need an extra light, and you also are where you will be driving and you may see halos. I don't mind. I will accept it. Okay, have it. So we did a binocular trifocal lens, and he was extremely happy. And he rang us a week later that he started operating, and he said, I am now suggesting all my ophthalmic colleagues in Madhya Pradesh. So if you want to put a multifocal, go to a Madhya Pradesh ophthalmologist, and they will come to you for panoptic. But this guy is propagating that to all these colleagues that go for multifocal lenses. So forthright discussion is important. That's what we learned. And he understood that. He was motivated, and therefore he was good. But not all are motivated. You can motivate to some extent, but don't be greedy or sort of push him, anything. This is the last case. Engineer, young, bright engineer, IIT graduates. He had the halos and glare, dysphotopsia, even before cataract surgery. So be careful doing anything which will aggravate, and that was the first thing. And he said, I'm driving motorcycle. And he's myopic, so he's not going to be happy with the reading distance he will have, because he's enjoyed the myopia as a natural gift, and it's birthright that he can read everything clearly all along his life. And if you change it, he's not going to like it. And on everything he has against, he had all that. And he wanted still that, my friends have warned against multifocals, and they had a bad experience. But whatever, I don't want these halos and glare. Please do something about it. I'm tired of this. Well, he had a both eye posterior subcapsular. At that time, we did a 2.5 low diopter multifocal, and some of these so-called extended depth of focus lenses, I won't name them, work as a low diopter multifocal lenses. So you can take it as a representative of EDOF lens, but actually it's not, but something like that. So we put that, and he was very happy because we prioritized at that time intermediate vision and distance for his computer and his work, and he was very happy, but he said, no, I don't want this lens again because I want a reading. I'm not able to read well, and I want to read well that. So luckily at that time in the transit phase, we got this lens, and we put that trifocal lens in the fallow eye a few months later, and that improved the entire range, and he got what he wanted. We warned him about the halos and glare for primary reason for what he wanted, the cataract, and warned don't compare and use glasses if necessary. But he didn't need any glasses, although on diffraction right eye with low ad needed, but he never used it. And because of his motivation and good performance generally, mentally, he adapted to these halos and glare so rapidly that in first 6 to 8 weeks' time, he said, I'm back to my motorcycle so happily, and in fact, I go over the weekend instead of one day alone. So you need to do that, and we could do that because we had time to discuss with him. These consultants at our clinic had a lot of explanation, counseling, and prepared him and did that. But the best example, and you will hear Shail talking about it, and we have a ophthalmologist here. We had the toric lens in one eye and EDOF lens, the true EDOF lens in the other eye, and you can match. You can match EDOF lens with trifocal lens. That's the beauty of neuroadaptation and the science, provided fundamental, you do the right calculation, as Dr. Ramamurthy said, correct biometric, achieve a targeted refraction. If you're ametropic residual, nothing can work. All these pamphlets and all the companies think is provided, they don't write that, provided you achieve less than half a diopter off target. If you are more than half a diopter, all of this vivity lens, panoptic lens, and eye hand, everything is down the drain. So prepare yourself to achieve the targeted refraction first. It's not because it's only a refractive surgery, but ultimately we want to enhance the lifestyle. And as you say, and we know that, We don't judge on the age or appearances. He may be wearing a cap or a hat, doesn't matter. So expectation management is the last one in counseling part, and I will learn from my colleagues sitting here that tell them that we are trying to reduce your handicap of vision and depend on the glasses, but it's not 100%. Do not promise anything. It will reduce, but you will be prepared to do that. And if you prepare the patient holistically from expectations, from reality, and make him understand you can have this, you can not have that, you will be the whole team, because the patient is also on our side. Don't take patient on the other side, because jointly we want to help him and the family. So do not always sitting on the other side of the slit lamp, actually is on your side. Keep in mind, would you do the same thing yourself to the patient sitting